and welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Welcome back, everyone. I'm so glad you decided to join us for another episode of the Research Works podcast.
Yeah, so am I, and I feel like we are on a bit of a knowledge quest today.
It's a good way to describe it.
Yeah, we are really looking forward to learning a whole lot about a very rare condition known as CDKL5 deficiency disorder. And on the show today to talk to us about CDKL5 deficiency disorder, we have Associate Professor Helen Leonard from the Telethon Kids Institute, who has just led a publication titled CDKL5 Deficiency Disorder, Clinical Features, Diagnosis and Management, which was published in Lancet Neurology just a few months ago. Hello and welcome, Helen.
Thank you. Lovely to be here.
Oh, it's lovely to have you.
Yeah, definitely a huge welcome. We've been really looking forward to speaking with you about this paper, and we're so glad that a paper like this has been published, because when it's in an area that we don't know very much about, to have an article like this is just gold.
Yeah.
Absolute gold.
Yeah, especially, one as comprehensive as this one.
Yeah,
and you're really looking forward to unpacking some of the details about this very rare condition, Helen, with you today.
Yes.
But before we start, we'll give everyone a bit of a bio so that our listeners can get to know you a little bit better. And then we will do our world famous icebreaker question.
Love it.
Associate Professor Helen Leonard has qualifications in medicine and public health. She's a Principal Research Fellow at the Telethon Kids Institute, Associate Professor at the University of Western Australia, and has held 2 NHMRC Senior Research Fellowships. Helen's research has mainly centred around child disability, but has been broad in scope, covering both common and rare conditions, using rigorous epidemiological methods, including cohort studies to describe prevalence, incidence, life expectancy and natural history, as well as qualitative methods where applicable to explore impacts for those affected and their families.
Wow, that is really wonderful, Helen. I love how, the first line we have is you have qualifications in medicine and public health. And if that's not enough, there's all this other stuff there as well.
Yeah.
It's brilliant.
Yeah.
Yeah, no.
And such, massive experience across a range of research methodologies as well, those really kind of large scale epidemiological studies, but also, the really those qualitative methods that help us to understand the family experience, which I imagine is really important when you're talking about rare conditions, isn't it?
It is. I've just noticed, and we were doing a qualitative study at the moment and about another disorder, and I'm learning so much more about the disorder from talking to the families that we didn't have already. It puts another focus on it.
There's only so much you can get from quantitative studies sometimes, and when you put the two together, we've learnt that ourselves. So it's wonderful.
Yeah. But I'm sure you're hanging out to hear what the icebreaker question is. So today I thought I would ask, and it sounds like a simple question, but when you think about it, it becomes quite tricky. Do you prefer summer or winter?
Well, I actually prefer summer. I mean, if I had a choice, I would say spring, perhaps. But I'll say summer. And I think that goes back to, I like the warm weather. I don't like the cold, and I don't like the grey skies. And I was brought up in Glasgow, Scotland, with a lot of grey skies. And I tried to get out of there when I was about 21 and actually I came to Australia originally when I was about 23, and I was a sun seeker.
Right.
So really, I do like the summer. And this year I'm feeling a bit hard done by because I went to the US towards the end of March, and I actually stayed there longer than I planned. So I missed all that lovely weather here.
Yeah.
And then when I came back at the end of May, we were into winter. And I'm feeling
and it's been quite the winter as well.
Yes, exactly. It has.
Yeah.
So definitely summer for me.
person.
Yes. Or you'll be looking forward to some warm weather coming up.
Well, I am, but I'm actually thinking of going back to the US for another conference and back to the winter for a little while. I've got 2 conferences, one on CDKL5.
Oh, wow.
Yeah.
Wow. Oh, gosh, there's so much to talk about. then.
That sounds like worth missing some sunshine.
Yeah. Wow. Gosh. Okay. So I do love summer, but then we get to the 40-degree days for a few days in a row, and I'm not so good anymore.
Yeah.
So then I really crave winter because I love wearing a good jacket, and I love sort of the idea of rugging up, and I love going to like places like in Europe, like Paris, and when it's cold, it's beautiful.
Yeah.
But when it's hot, it's not so nice there.
No.
So I feel like I get why you say it's not an easy question because you think about the different places. So I remember being in Paris and it was hot. And I suffered. I did not like it one bit.
No. Well, they're not really equipped for heat. Like here, we've got our great big air conditioning units, and you can just blast some cold air.
Yes.
But places in Europe and the UK, it's a couple of hot days, and it really does
does get to you, doesn't it? So maybe it's more. It depends which hemisphere you're in.
Yes.
So maybe look, I think maybe now that I'm in Australia, that is definitely summer, provided I have air conditioning close by.
Yeah.
And then if I'm in Europe, maybe winter, provided there's central heating everywhere.
Yeah,
and there
which
usually
there is.
is. So so there you go. The most ambiguous answer.
I like it. On the fence.
On the fence. Lovely. What about you?
I love that everyone takes the approach of the grass being greener on the other side. That those of us who grew up, well, for me, who grew up in Australia, I love the idea of that really cold winter weather in Europe and the UK and places like that. But I can appreciate that, an extended period of time with a lot of those winters might kind of wear you down after a while and you would want some sunshine. But I have all these nice winter clothes that I bought when I was over there that I only get to use when I'm over there because you just don't get to use coats and things here all that often. So I would choose winter just so I get to reduce the cost per wear of my nice coats.
When you justify, I'm going to use it so many times and it lasts so many years. I get that. It's a really good one. No, it was a deep question. It sounded really simple. I like it. Yeah. Well, on that, let's get into today's topic.
Yes.
So the aim of this review was to synthesize the current knowledge about CDKL5 deficiency disorder, including epilepsy patterns, developmental course, functional abilities, and comorbidities. The review also goes on to focus on clinical variability within the disorder and new knowledge occurring about genotype-phenotype relationships, differential diagnosis, genetic testing, and comparing CDKL5 deficiency disorder with other developmental epileptic encephalopathies at the time of diagnosis. The paper summarizes the evidence regarding clinical management and the current landscape of clinical trials. And with CDKL5 deficiency disorder being more commonly diagnosed in infancy, it is just vital that clinicians have the best available information to provide to families.
Thank you for that summary, Dana. And thank you for taking on the big words this time.
Yes. That was a big one.
Did very well.
Thank you.
Helen, let's start right at the beginning because a lot of our listeners and us included may not be all that familiar with CDKL5 deficiency disorder. So could you explain a little bit about what it is?
Yeah, certainly. So CDKL5 deficiency disorder really is a deficiency of the CDKL5 protein, which is caused by a mutation, or now they talk more about variants, a pathogenic variant in the gene. It was the name CDKL5 deficiency was really only adopted in the literature a few years ago in 2018.
Right,
but we did know about the disorder before then, and we originally called it CDKL5 disorder.
Right.
But somebody said, you can't, it's a deficiency because there's also a duplication of CDKL5. So you might be able to have too much CDKL5 or too little CDKL5. So the deficiency represents too little, and that's how it got its name. But would you like me to tell you about how it actually was identified originally?
Yes, please.
Yes. Well, that was way back in 2004.
Okay.
And I've got a sort of personal story that I'd love to share with you about this. And that is, there is some sort of association with Rett syndrome. I in 1993, way back then, I established an Australian database for Rett syndrome, which was a condition. We didn't know the cause of it. It mainly affected girls who appeared to be developing normally initially and then lost skills and developed these unusual hand stereotypic movements.
Yes.
And that was about all we knew. There had been a few conferences in Europe. And I had a mentor, a doctor by the name of Dr. Hockey, and I worked at Disability Services Commission. I said, I need a topic for my dissertation. She said, Rett syndrome. But we only had a small number of girls in Perth. I said, it's got to be bigger. This is an epidemiological study. So we go Australia-wide. So that's why I started in 1993.
Wow.
And I had 134 patients' cases when I started.
Okay.
And then a few years later, in 1997, I had a call from a couple of colleagues who were from WA or were based in WA, but were we're going around Australia, and they were looking at familial cases of autism. They were visiting families where there was more than one case of autism. And they gave me a call and they said, we visited this family in New South Wales, and there are twin girls, one who has got typical autism, and the other twin, we believe, has Rett syndrome. I said, oh, that's interesting. So I talked to the family, and it turned out this girl appeared to have Rett syndrome, except that she had developed seizures very early in life, which was unusual for Rett syndrome. And so there was a variant, they called the early-onset seizure variant of Rett syndrome. And we thought this is what she had. So we enrolled this child and her parents in the study. But then just a few years later after that, in 1999, the cause of Rett syndrome was identified, which was mutations in the MECP2 gene.
Right.
None were found in this family at all in either of the twins. And also there was a brother who died of a severe neurological disorder, etiology unknown.
Right.
So, what was causing this disorder in this family? So I was another few years later, in 2004, when a combined study from Professor John Christodoulou in Sydney and Professor Joseph Gex from Adelaide identified a mutation in the CDKL5 gene in this family, in the affected members of the family. At that time, it was also called STK9, just to complicate matters, but since then we've been calling it CDKL5. So I was an author in that paper, and at the same time, there was another paper published from Europe, with similar findings, and that was the start of my knowledge on CDKL5. And in fact, in our international Rett syndrome register, which we developed after the Australian population-based one, which the purpose of that was to be able to compare phenotypic and genotypic characteristics in Rett syndrome, we had quite a number of children with CDKL5, and we were calling them atypical Rett syndrome at that time.
Wow.
So we then did a paper where we compared their characteristics with the characteristics of the children with a mutation in the MECP2 gene and found there were differences. And that really was the stimulation, the prompting to say, well, we need an international CDKL5 database. And we actually established that in 2012, started collecting cases we started with those that were in the Rett syndrome one, moved them over to the CDKL5 one, and then started. So that was started then, and we've now got between 400 and 500 cases internationally on CDKL5. So that was sort of the story.
Yeah.
I'm so glad you shared that.
That's incredible. And, you know, you've obviously been so involved in, you know, the understanding of this disorder from the start. From that kind of very initial discovery. That's incredible.
Yes. I still talk with the mother of the twins.
Wow.
I talked to her a few months ago. And you do develop these relationships as well.
Yeah.
And it sort of enriches your research, I think.
Yeah, absolutely.
Sure.
So with CDKL5 deficiency disorder, what are some of the characteristics that are unique to this disorder, say, compared to Rett syndrome, or, you know, you said that there's also duplication of CDKL5. How is it distinct from?
Yes. Well, the main one really is the early onset seizures.
Sure.
And the seizures develop usually within the first 3 months of life. But the median age of onset is 6 weeks.
Wow.
So most develop at that time.
Gosh.
Yes, which is very, very hard. Yeah. And about 90% of children will have had seizures by the age of 1 year.
Wow.
But more recently, we've actually we're just about to publish any day a paper looking at seeing whether we can predict what factors may predict the age of onset the age of acquisition of developmental milestones.
Yes.
And one of them was that the later the onset of the seizures, the better the child's development is going to be, which is, what you might expect.
Yeah,
but
true.
we put this into a mathematical model.
Wow.
So they develop, but then often, in almost about half of the cases, there is what we call a honeymoon period, which seems to be pretty distinct to CDKL5 as I we've got a period where the seizures either resolve or go away, but just for a short time. Sometimes, which must give parents great hope, and then they come back again.
So that's without medication. It would just...
they probably are on medication, yes.
Mm.
But later on, when they come back, they really they don't respond to any medication generally, and that's one of the things.
Yeah.
So I mean, one author in a small early series of cases divided the epilepsy pattern into 3. First of all were the early convulsive seizures, which, the presentation.
Yep.
Then infantile spasms. Another name for that is West syndrome. And they're when the whole body sort of stiffens like that, and but they're short-lived, although they can occur in clusters, and they're very difficult to treat. And then after that, there's the refractory seizures, and they can be multiple different types of seizures. They're having one type of seizure, then it suddenly changes to another, and very, very difficult for the families, and not responding to medication.
Wow, that's so challenging.
It is. So, I mean, about 3/4 of children have 1 or more seizures every day, and about half are on 3 or more anti-epileptic medications.
Wow,
which is really shocking because they have their own side effects as well, which is difficult.
Yeah.
So a question on that, just going back, you said about infantile spasms, which you sort of said is also called West syndrome.
Yeah.
Are they interchangeable, those terms? Because I often do see them come together.
Yeah, well, more or less. I mean, it's not... Neurologists talk about syndromes, and they don't mean the same type of syndrome as a genetic syndrome. I would say Rett syndrome.
Yeah.
See, that's a syndrome. But they've got lots of syndrome names for their epilepsy. They've got Lennox-Gastaut as another one, and that doesn't mean that it's caused by anything. It's a picture, and I would say that West syndrome probably is very similar to infantile spasms. There is an EEG change called hypsarrhythmia, which sometimes occurs, but not always, along with the epileptic spasms. And we found that in some children with CDKL5, they have the hypsarrhythmia, others don't.
Right, okay.
It's a very complicated picture that you're trying to pull together, isn't it?
It is. Yes.
So how is a diagnosis made for CDKL5 deficiency disorder?
Right. Well, that has sort of changed over time. When after our original paper, the sequence, to diagnose it, you had to sequence the gene. And that was done in Sydney, in Australia, that was done in Sydney, where the research was carried out. But CDKL5 is a large gene. It was a laborious process. It's quite expensive. And in Australia, children who were in New South Wales were eligible for that testing. But children elsewhere weren't unless somebody paid the cost, which was quite substantial. Wow. I can't remember exactly how much it was. Wow. So at the beginning, I think in Australia there was a bias towards, those who were eligible for testing, getting tested and getting a diagnosis, and those who weren't were not. Yeah. And that's my personal opinion. And I think but that happens a lot with genetic testing, which is so rare. Yeah. But now, can't tell you exactly when, but now what we have is epilepsy panels. And they're panels which contain about 100 or more epilepsy genes, and they can be tested if children present with these seizures, they can be tested for all of these genes at the one go. And that's the way that it's done now. Okay. It can either be done blood, but also from saliva now. Oh, wow. Yeah, which is amazing, really.
So good. In terms of accessibility for some of these children, I imagine that's a much more convenient way to try and
yes. And the samples are often sent overseas. I mean, I don't know exactly which labs are doing them, but often they go overseas and they're done very, very quickly. Right. Yes. So it's much more accessible now, but it does depend upon the country.
Of course.
In Europe, they tend to be much more sort of population based in their testing than they do here. And in some countries, they won't have the testing at all, obviously.
Yeah, of course. Yeah. So what is the incidence of CDKL5 deficiency disorder?
Right. Well, that's an interesting question, which follows on from what I've just been saying. So the incidence that's in some of the literature now is 1 in 46,000. Okay. And that was from a Scottish study, a Scottish population-based study, where they tested all children who were presented with an epileptic encephalopathy, neonatal early seizures, and they over a period of 3 years they identified 4 cases of CDKL5. So they made this estimate based on the 4 in the Scottish, I think it was the west of Scotland population, and the actual estimate has wide confidence limits. But when people are quoting it, of course, they forget about the confidence limits that are wide, and they say it's 1. Yeah. So we also used our Australian data to make an estimate. And we did it differently because we didn't have rigorous testing of all children here over a period. So we just used our data and we used the time the time that the children were exposed. And we did have some older people in the study. So those who were diagnosed, but they're probably a whole lot the same age who were never diagnosed. Yeah. So we got a much lower instance. We got an instance of 1 over 476,000. So 10 times less than the Scottish. Yeah. So I would say, pragmatically, probably the instance between the two. It's probably a bit less than 1 in 46,000. But we could probably revise our figures now because we do have a few more younger children in Australia being diagnosed, and that would probably give us a different figure. Yeah. But people don't realise that you have to have a population study to be able to provide incidence and prevalence. And one of the things that happens in the literature, something is written down in one paper and it's adopted and adopted. It's used all the time, and it may be wrong.
Yes.
That's one of my bandwagons.
Yeah, no, it's a good bandwagon to jump on, I think.
I think it's important.
Yeah, so we've talked about rare disorders with Gareth Bainham previously, but am I right in thinking that CDKL5 deficiency disorder would be considered ultra rare?
Yeah, I think so. I checked the definition of ultra rare, and it was it was supposed to be 1 in 50,000. Now we're
Okay.
1 in 46.
Oh, okay.
But I would
Right.
say it's probably less than 1 in 4. So
Yeah.
probably I would say, I mean, it's much, much rarer than Rett syndrome, you know, although Rett syndrome seems to be becoming rarer since COVID appeared.
Oh,
No, I don't know.
Yeah.
No, we were not picking up as many children as we did.
Interesting.
I don't know why.
Yeah.
But yeah, I would say that that it is ultra rare, which makes it more difficult to study. Yes,
Study
yeah.
and support, and for families to find other supports.
Yeah.
Yeah.
Exactly.
Yeah.
Exactly.
Yeah.
Yes. Yeah. Although families have got their own online support groups, which they do find
Yeah.
very helpful.
Yes. Yeah.
It's one of the benefits of things that are online, aren't they? To be able to have, like, I know you've got the international database, it's good that we can do things like that. And for families, similarly so, is that they've got, online pages that they can find, light
Yes.
stories. Because it'd be
Yes.
very, very isolating, I imagine.
Yes.
Yeah.
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 Exactly. Yes. Yeah.
So you've spoken to us a little bit about in terms of the epilepsy, which is very, very high numbers there in terms of what that looks like for children, and the relationship that you sort of touched on there with regards to developmental milestones. And I know you're still looking
Yes,
at that,
yes.
and the authors are still looking at that. But in this paper, you did sort of go through, and you have this lovely figure 1.
All right,
I love
yes.
a good figure with colours.
We do.
It was a beautiful
Yes.
figure, and I do encourage everyone to have a look at this
Yes.
for an
Yeah.
overview.
Just highlights that I'm definitely a visual learner.
Yeah, for sure. I was really attracted to that. So I thought we'd just talk through that a little bit, because I'm really interested to know about, gross motor, the acquisition of certain skills. And you did have some data around that, which I thought was interesting.
Yes, yeah. Well, with girls who are better than boys, it was about 75% of children who learn to sit up, of girls who learn to sit up independently by the age of 5, which isn't that good.
Yeah.
And it was only a third of boys who could sit up independently by the age of 5, which is really, not good.
Yeah.
Although I'll tell you a bit more about the boys in a minute.
Yeah.
But and about a quarter of children actually learned to walk. That,
Wow.
and similarly, hand function is poor, and communication is poor. A small number, and there are those, and I think they're going to tell us something in the future. A small number can talk, can interact. Well, quite a few can interact, but actually carry on conversations.
Yeah.
Yeah. And I think that's going to be a very valuable group to look at. And I've actually been talking to a researcher in Boston about a study on the more higher functioning children.
Yeah. Yeah.
But because, but generally that is a small proportion.
Wow.
But that may teach us something
Yeah, for sure.
about
For sure.
Yeah.
and maybe help with identifying treatments if we know what sort of mutations these children have.
Yeah. And you mentioned, obviously the discrepancy between boys and girls with regards to that milestone of sitting independently. And it just got me thinking back to, the diagnosis of the disorder and the close ties with Rett syndrome. Do you see more girls diagnosed with CDKL5 deficiency disorder than boys?
Yes,
Right.
but not like Rett
Not like
syndrome.
Rett.
No.
So about 4 to 1. Yeah, yes,
wow.
yeah. I did see a paper the other day that said it was 12 to 1, and I thought, oh gosh, that's not what I've been quoting.
Yeah.
But I must check the figures again.
okay.
We're also finding there are boys who are mosaic. Who don't have the mutation in every cell in their body, and they tend to be quite high functioning. And
Okay.
so that's sort of changing the characteristics when we compare boys with girls, because we're getting more of these mosaic boys in the study, and they possibly weren't identified before. And we don't know the percentage of mosaicism exactly, but that is very interesting. So there's a few quite high functioning boys, as well as generally the boys who are not doing so well.
Yeah.
Yeah, that
Such a spectrum, isn't it? Such a
yes,
spectrum of
it is
skills.
a spectrum. It definitely is. Yes.
So one of the key characteristics that we sort of all know quite well in girls with Rett syndrome is the intense eye fixation, and they're really looking at you. It is quite different though in this group of children, which I guess is a very distinguishing factor. Can you talk us through a bit about that?
It is.
That interesting.
Yes, they've got very poor eye gaze and just the opposite from Rett syndrome.
Yeah.
And this is because they've got this condition, remember you might call it a syndrome, called either cerebral visual impairment or cortical visual impairment, depending upon whether you're in Europe or somewhere else.
That's right. That's right.
So there isn't actually any abnormality in the eye or the visual pathways. It's actually a cerebral cause of their not being able to see. And that appears to affect about 75% of children with this disorder.
Yeah.
And but I think it may improve over. We don't have the data yet. I think it may improve over time. But if it's identified early, it could be a marker of poor prognosis later on.
Yeah.
But so we need to know a lot more. The studies that have looked at it intensively have been quite small, 20 cases. Sure. This is something that we need to look more into. Yes. Yeah.
And what about some of the other comorbidities in CDKL5 deficiency disorder? Yeah.
Well, one of the worst appears to be the sleep disturbances, which you mentioned a personal experience of.
Yeah.
And in the study which we published in 2015, I think, we felt that about 87% had some sort of sleep disturbances.
Wow.
And again, talking to families, I can remember talking to a lady in the UK, and she said to me, I have never slept a whole night since her daughter was in her 20s or something.
Oh, wow.
It really can be very, very hard on families.
Yeah.
And I don't know how hard it is on the children, because somebody said, this is an anecdote, but somebody said, well, the child, they go on, they don't sleep all night, they don't sleep for 3 days, and they're still operating.
Yeah.
Wow. So we need to know a lot more about, but for a lot of families, it really is one of the worst comorbidities of this disorder.
Yeah.
And that also when we examined parental emotional health, that was one of the things that affected that. So it is sleep. Behavior problems we don't know a lot about, but I actually suspect that they are more prevalent in the high-functioning children.
Sure.
They manifest as such. And anecdotally, we're making videos of children for a study, and the ones that couldn't do the video were the high functioning. Said they won't cooperate. And I thought, you're lucky your child won't cooperate.
Yeah, they've got their own ideas about what they're doing.
Yes. So that's something open for research. The behavior.
Yep.
Another is gastrointestinal problems, about 87%. And again, that occurs in other neurodevelopmental disorders, as you will know.
Yeah.
So that's constipation, reflux, ear swallowing. Yeah, the ear swallowing is, they do have some of these breathing abnormalities that are characteristic of the autonomic breath holding, but not to such an extent. And we don't really know what the connection is there.
Yeah.
I mean, one study I wanted to do was really look at those characteristics which are typical of Rett syndrome in CDD and see whether there was a particular mutation group or why some of these children were having them more than others. Another is the hand stereotypies.
Yeah.
So they have hand stereotypies, but we were only discussing this yesterday. I'm not sure that they are a measure of severity. I think it might be the milder children who have more hand stereotypies. But we don't know that yet. So there's, as I say, there's sleep, there's GI problems, there is respiratory problems.
Okay.
And about I think about half will have had lower respiratory infection in the first 5 years of life.
Wow. Yeah.
But they may become less frequent then, although I think about 20% would have had overall would have had an episode of pneumonia.
Yeah.
So
Is there any link between like feeding and respiratory issues?
Well, there may be, so that about I think a third of children, or no, a quarter of children, a third to a quarter of children have had a gastrostomy, and that was why we wondered whether the respiratory infections were becoming less frequent as they aged, because they then more likely to have a gastrostomy.
Yes,
but that we actually did a study using linked data in WA, not just on CDKL5, but on children with intellectual disability. And we weren't, although we looked at the hospitalizations before and after the gastrostomy, and although they generally deteriorated, not deteriorated, improved, there were fewer hospitalizations, we didn't actually see that with hospitalizations for respiratory conditions, which is what we were expecting to see.
Yeah, of course.
Yeah. So, in fact, talking about that's a very pertinent question, because we've just been asked to look at the impact of gastrostomy and growth in CDD. So we're looking at, unfortunately, we've got what would be ideal for this would be to look at before gastrostomy and after gastrostomy and what the changes are. But so we have, in a group of children, we have a follow-up study, but we only have a small number who actually had their gastrostomy between the 2 points, which is what really we would like to be able to say, they're this. So I'm not sure how far we're going to get with that, but we can look at growth probably before and after gastrostomy. So that is another important research question that we have to work on.
Yes. Can I ask a question with regards to, something that I've seen as well, and you mentioned in your paper, was the instance of like movement disorders, chorea and dystonia, which in my experience I have seen clinically as well. Yes. What's the incidence of that? And are they related to any sort of neuroimaging findings, or is that,
I think it's pretty low at the moment, the dystonia. Actually, we were even talking about this yesterday, because we were talking about, we're developing an outcome measure for CDD, and we're doing factor analysis on the various comorbidities, and dystonia came by itself.
Right.
Where are we going to put it? And similarly with the chorea. I think they're identified at the moment. There's not a lot of data, probably just about 10% or less, but they are very difficult to manage and very, very severe. So, and the chorea as well. I haven't. I don't think we've got any videos demonstrating that. But that's an area, and of course the MRIs have only been in research. There's only a small amount of data on MRI neuroimaging, and I don't think they connected it with the chorea. But so that's another area.
Another really important research area. Yeah.
And it sounds like so much variability in terms of the different comorbidities that these children with CDD might present with. And so, it's really each time quite a unique picture that you're looking at and trying to kind of piece all those pieces of the puzzle together. Right?
Exactly. Yes.
Yeah. So let's talk a bit about clinical management then. What's the current evidence-based information on how to manage children with CDD clinically?
Right. Well, there isn't a lot, although there is a paper that's just been published probably in the last week, two weeks.
Hot off the press.
on the management guidelines. And it has used a Delphi technique to ask doctors what they think should be done. But it's only on opinion. That's the problem. It doesn't say, we haven't really got much evidence at all. And I was surprised, because one of the suggestions was that they all should have an MRI. And I thought, do they need, what is it going to, how is it going to help management? Because so far what has been shown is fairly non-specific, but it's amazing what clinicians say. I mean, you can over-investigate as well. You know what you want. So there even I went reading that paper, just read it the other day. You know, there's not a lot of background evidence. It's really opinion.
Sure.
But I mean, the work that has been done is a few trials on anti-epileptic medications. And the most successful one is a trial on a drug called ganaxolone, which is neurosteroid, and that did show an improvement in motor seizures. So that drug is now going to be available in the US, and hopefully it will Hopefully it will also be available in Europe. I don't know when it will be. Available in Australia. I actually, and I must answer the email. I had an email from a lady, I think she was in South America, saying, "Can you send me a prescription for ganaxolone?" I thought, unfortunately, I can't email that to you. But that just shows you how desperate these families are.
Absolutely,
You know, it's so sad, and in these sort of countries, they're more disadvantaged. Yes.
I mean, on that one that's you often hear circling around when it comes to seizure management is CBD. Where is CBD when it comes to where does it fit? Does it fit?
Yes. Well, it does. And in fact, that was in that the guidelines I was managed. The doctors all recommended CBD.
Right.
I mean, there is only one study really looking at it in CDKL5, and that did give some one controlled study. Shall we say it wasn't that controlled, but it did give some positive results. Although I think there might have been a little bit of flaw in the methodology. But we did a study where we asked families, and they were all so positive about it. But when we actually tried to compare their seizure frequency before and after, we weren't showing any positive signs. But families do think it helps. So I mean, I'm not saying that. I'm not saying that our data was what we had, and it might not have been exactly before they started the CBD and just after, but they generally were.
Sure. Yeah, and that the epilepsy side of things sounds like the most debilitating thing that they're trying to manage. So I mean, the fact that you have someone on the other side of the world emailing you, asking you for a script for a medication that might help address that, it's you can understand that they will, take anything that's available to them to try and help with
that's
that.
right. Exactly. Yeah.
So, we've talked about the comorbidities and the clinical presentation, and given the impact of functional mobility and the developmental milestones that we talked about earlier, what do we know about the role of allied health clinicians? So physiotherapists, occupational therapists, speech pathologists form the basis of our listeners. I'm sure they'd be really interested in what kind of practical things they can be doing to support these children.
Yes. I mean, at the moment we don't have really any evidence. When we I don't think it's published, but when we asked the families about whether the therapies help, they said yes. But when we did this study, which had just been published about the predictors of developmental milestones, we didn't really, having had therapy in the first year of life, didn't really add much to the increased likelihood of achieving milestones. The things that did matter were more their genotype, whether the child was mosaic, the age of onset of epilepsy. But I think I certainly wouldn't say stop because we haven't got any evidence. Because the families definitely, I think we did ask them and they said, they thought it, but we haven't got any hard evidence for that. But there are certainly a lot of things that that can be done, and I think. Weight bearing early, standing frames, etc., are really important. And being aware of the visual impairment when they're working with the children is important as well.
I think there's a lot of principles that we spoke about that that we can take a very transdiagnostic approach to. You know, at the end of the day, it kind of falls under a neurodevelopmental disorder, and like, you know, there's some features that we need to be aware of. Obviously, with CVI, whether it's cortical or cerebral vision impairment, whatever you want to call it. CVI, that's right.
Works for both.
You know, knowing that sleep may be more troublesome, so looking at some sleep hygiene. You know, like I'm thinking, even in terms of, you know, in terms of developmental milestones, I think it's important to understand that probably a lot of that's to do with their genotype and the phenotype. Like there's some very specific things there. But if you take a very sort of functional approach, meeting the child where they're at and looking at things like, you know, we talked about air swallowing and gastrointestinal. I go, well, you know, put them in standing frames or, you know, some walking frames if they're able to move, might be really comfortable for their gut. And we were talking about lower respiratory tract infections and possibly pneumonia, or being upright rather than supine, because these kids have probably spent a lot of time on their backs. You're getting deep breathing and, you know, there's
positioning considerations. And
that's right. So in the meantime, I feel like you said, you know, that there is something that's helpful. We need to identify what those active ingredients are. But in the meantime, we could be doing these things.
That's right.
That's right.
Quality of life.
That we know to be effective.
No, you're right. Yes.
So, Helen, where to from here? It sounds like you're have been incredibly busy and continue to be incredibly busy with all of this work. And so what are the future directions for CDKL5 deficiency disorder research?
Well, I think one in general is finding out more about the comorbidities that we don't know about. You know, like the behavior. You know, how much of a problem is this, and what can we do? And also more about sleep. That's on our list of topics that we really want to get into. But overall, we are working on a grant to develop outcome measures for clinical trials, because it is hoped that there might be genetic treatments available in the fairly near future. But you cannot you cannot do a study effectively without good outcome measures. So that's what we're working on, and in combination with the Centers of Excellence in the US. And the ones that we're doing specifically are the gross motor function and the hand function. And we're measuring that through videos. So we've collected, over 100 videos and over 100 children, and they're, we're scoring them, and we're developing this into an outcome measure.
Oh, that's wonderful. Well, we'll be chatting to you about that.
Because that kind of has a flow-on effect for those, the therapeutic interventions that we're talking about. Like you say, without a good, robust outcome measure, you can't determine the effectiveness of these therapies for these children.
That's right. So that's really, exciting. And often therapists help us with making the videos for some families.
Oh, it's always lovely to be able to work together on that. Gosh, Helen, I feel like you, like you said, knowledge quest. We definitely I learned so much in this time, and I hope all the listeners have as well. Helen, we just want to thank you so much for your time and coming in to talk to us about this today. And I'll be going back to listen to this many, many times over, because it's just so much great information there. So thank you. Yeah,
and for all the work you do advocating for these families as well.
Not at all. It's very important, and this is our 10th anniversary year of the database, so we're hoping to promote that sometime before the end of the year.
Oh no, congratulations on all that work. And so to all of our listeners, if you want links to the paper and just to know a little bit more about Helen as well, head over to our website and researchworks.net. And of course, there's a CPD form there that you can fill out if you want to keep this as a part of a record of your PD requirements. But for now, I guess it's a thank you and a goodbye, and we'll talk to you all again next time.
Thanks, Helen.
Thank you so much, Helen. Bye.
Bye.